You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 17th, 2017. This podcast will be mostly an AHA review. I'll talk hypertension guidelines, blood pressure measurement during a sprint trial, direct-acting oral anticoagulants and cardiac device surgery, canakinumab and inflammation, and an important study on heart failure quality measures. First up, obviously, is the hypertension guidelines. This was a 192-page document with more than 900 references. It had 5 main areas of emphasis. The most important, and the first one I'll mention, is the new classification system. The label pre-hypertension is now out. Normal blood pressure is defined at less than 120/80, elevated at 120/129 systolic. Stage 1 hypertension is systolic between 130 and 139. Stage 2 hypertension is a systolic at least 140. And hypertensive crisis is labeled as a systolic greater than 180 and or diastolic greater than 120. Now, an accompanying paper published along with the guidelines confirmed that these new recommendations will increase the number of people diagnosed with hypertension. The prevalence of hypertension will go from 32 to 45% in the U.S. That's more than 100 million people will now have hypertension. But this is an important point. The number of people in whom the guidelines call for medication goes up by a much, much smaller amount than that. And that's because this document calls for lifestyle modifications in many of the low-risk individuals. Now, the other big change is the recommendation to use cardiovascular risk, and this is similar to the statin guidelines. The writers recommend estimating 10-year CV risk with the ACC-AHA pooled cohort equation. Specifically, for instance, in stage 1 hypertension, the recommendation is to treat with non-drug therapy, non-pharmacological therapy alone in low-risk patients, and to use both drug therapy and non-pharmacological therapy for high-risk people in the stage 1 category. I guess the other big change is the treatment goals. Now, old guidelines called for less than 140/90 as the goal. Now it's less than 130/80 is what we're shooting for. Now, this likely represents a compromise with the sprint trial, which found better cardiovascular outcomes in non-diabetic high-risk patients treated to a goal of 120 systolic. Another controversial part of the guidelines is clearly going to be the hypertensive crisis with blood pressure greater than 180 systolic or greater than 120 diastolic. On social media already, numerous emergency department doctors have noted that patients in pain or in similar situations like stressful situations can often reach that number. The final point is that the writers spent a lot of time on the measurement of blood pressure. They emphasized the use of automated cuffs and paying attention to home blood pressures. And this latter point leads me to an important substudy of SPRINT that was also presented at AHA. This one addressed the concern that attaining sprint blood pressure goals may lead to overtreatment, and that's because the blood pressure measurement technique in the trial was not representative of the real world. In fact, it was pretty darn ideal in the trial. In sprint, blood pressure was taken with 5-minute rest periods. They used automated cuffs. They used average measures, and often there was no staff talking to the patients while they were doing their blood pressure. So this particular substudy was a survey among sprint sites to determine whether blood pressure was taken attended or unattended by staff, and whether or not that factored in outcomes. So the research group looked at 4 different types of subjects that were in a sprint trial. Those that were always alone during the blood pressure measurements, those that were never alone, those that were alone only during the rest period before the blood pressure was taken, and those that were alone during the blood pressure. And they found no difference in the primary outcomes. They found no heterogeneity of treatment effect for total mortality by blood pressure measurement technique. The adverse effects were also not different. So this is somewhat reassuring, but these data are not definitive. But, however, I've already sent an email to my group that I think that if we are to adopt more aggressive targets, 130 versus 140, for instance, we should strive to simulate sprint-like practices. I mean, right now, we don't use automated cuffs or rest periods before our blood pressure measurements, and I think we should. The next topic is a study on use of direct-acting oral anticoagulants during device surgery. Now, Canadian researchers, led by Dr. David Burney from Ottawa, have once again added extremely useful information for practicing EP docs. The clinical question here relates to holding or not holding DOACs before and after cardiac device implants. Now, this group has previously showed in the Bruise Control 1 trial that continuous warfarin, doing the surgery with patients on warfarin as opposed to using heparin bridging, reduced the incidence of hematoma in patients who had device implant. So not stopping the warfarin was beneficial. The Bruise Control 2 trial tested uninterrupted DOAC therapy versus interrupted DOACs. And the answer was crystal clear. There was no difference in clinically significant hematoma or any other measure. So this is a good example of a negative RCT that's producing extremely positive results, namely that if a clinician feels a DOAC continuation is preferred, then high-level evidence says he or she can proceed without stopping the anticoagulant. Fourth topic is inflammation and CANTOS. Now, when I spoke with Dr. Paul Ridker at ESC after his presentation of the original CANTOS trial, which was a study of canakinumab, a monoclonal antibody targeting interleukin-1 beta, and that study resulted in lower inflammation and improved cardiovascular event rates on the drug, Ridker made the point that he thought those who responded more would likely benefit more from the drug from the standpoint of cardiovascular outcomes. So at AHA, he presented this pre-specified sub-analysis of CANTOS that was also simultaneously published in The Lancet. This study was designed to address how much CRP reduction matters in terms of cardiovascular outcomes. The researchers looked at the rates of MACE, major adverse cardiovascular events, and all-cause mortality according to on-treatment concentrations of high-sensitivity CRP. And they found, interestingly, that those who took the drug and got to a CRP below 2 had a 25% relative risk reduction of MACE versus no reduction in those patients whose CRP stayed above 2. And they found the same for CV mortality and all-cause mortality. Below CRP of 2, benefit. Not below 2, no benefit. So two key messages here, I think. One is that this could be clinically useful in that you can imagine a scenario where you start the canakinumab and see if it reduces CRP below 2. If it does, then continue it. If not, perhaps stop it. The other message is more about science, and that is if those patients who get CRP reductions get better outcomes, this strengthens the argument for causality in the inflammation-heart disease relationship. Because remember, one of Hill's criteria for causation is a biological gradient, and this looks to be like a clear biological gradient. Final topic today is heart failure measures. Now, in the United States, readmission to the hospital after treatment of heart failure is considered a marker of poor quality care. And so strong is this conviction that policymakers enacted financial penalties for hospitals that have higher rates of readmissions. But a provocative paper from very respected researchers presented at AHA called this penalty policy into question. The researchers used clinical data collected as part of the Get With the Guidelines registry from hundreds of hospitals. And in short, they compared rates of readmission and mortality before and after this penalty was implemented. And they found that readmissions did decrease after the penalty, but here's the kicker, mortality increased significantly. Now pause on that for a moment. A policy aimed to reduce mortality in millions of patients may have increased it. Now I want to be careful, the researchers want to be careful, they stated it, that this is an observational study and you can't jump to causation, but this is provocative nonetheless. Harlan Krumholz and his team at Yale, however, feel otherwise. They've been critical of this paper. This Yale group published a paper earlier this year which essentially found the opposite. And in the Yale paper, they used administrative claims data on a much larger sample size across the U.S. and found that readmissions went down after the penalty and mortality was flat to improved. But their study had a little extra twist in that they were able to look more closely at individual hospitals and found a statistically significant but pretty weak correlation between readmissions and mortality on an individual hospital level. So in other words, their conclusions are that individual hospitals that did well with readmissions also did better with mortality. My take here is that at best, there's uncertainty on this important policy, but at worst, a well-meaning policy may be harming people. The potential of harm, I believe, warrants more rigorous study of policies before they are enacted and closer scrutiny of their performance after they are implemented. We don't let drugs or devices on the market unless they've been proven effective and safe. Why should it be any different for policies? So a note before I close. Next week is a holiday, and I'll take a week off, and then This Week in Cardiology will return the week after that. So that's it. Thanks for listening. I'm grateful that you did. This is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.